Assalamualaikum and a very good morning, afternoon to everyone. I will be giving the last lecture in the series of diseases that can cause vertigo. I'm going to talk about Meniere's disease. I'm sure many are familiar with Meniere's disease. So let's start. I'll be showing my screen. So why are we familiar with Meniere's disease? Because it has been around for more than 100 years. In 1861, Prosper Meniere was the first to recognize that vertigo, balance, and hearing diseases reflected a lesion in the inner ear. Prior to that, medical people or medical fraternity thought that all this problem comes from the problem in the brain. I don't know about everyone else, but I always got confused when I'm with a patient. I will think that they have Meniere's disease, but it doesn't sound so straightforward. So if you type Meniere's disease on Google Scholar and you put the filter to 2021, about 500 article will come up. So there's a tremendous amount of work being done on Meniere's disease. Why is that? Because many things are still uncertain about it. In 2015, there's a jointly formulated new diagnostic criteria done by the classification committee from the Bayernese Society, from Japan, Korea, the Europe, and also America. So this is the new diagnostic criteria. It divides Meniere's disease into definite and also probable. And definite is diagnosed when there are 2 or more spontaneous attacks of vertigo, each lasting 20 minutes to 12 hours, with a documented low to mid frequency sensory neural hearing loss, which can happen prior, during, or after the episodes of vertigo, and with associated oral symptoms such as tinnitus and fullness in the ear. And these symptoms are not accounted by other diagnoses. For probable Meniere's disease, patient can have 2 episodes of vertigo or dizziness lasting from 20 minutes up to 24 hours with fluctuating oral symptoms. So most of the time, patient will ask us, why do I have this disease, doctor? The etiology, why it happens, is not completely clear. But Meniere's disease has been associated with endolymphatic eye drops. Yeah. In 1937, British and Japanese researchers has found in the human temporal bone the evidence of endolymphatic eye drops in patients who has Meniere's disease. And this confirmed the theory by Prosper Meniere in 1861. So how does endolymphatic eye drops develop in this kind of patient? Morita, in their study of 53 temporal bones, has found out that the endolymphatic volume in the saccular, utricle, and also cochlear duct in patient who has Meniere's disease is more than 200% the volume in a normal patient. Another study found that a patient with Meniere's disease has vestibular fibrosis connecting stapes foot plate to the utricle macula. And this gives positive Hannibal sign in patient with Meniere's disease. Another study has showed that there is increased glycoprotein synthesis in endolymphatic sac in patient with Meniere's disease, which increase the osmosis, which develop into endolymphatic eye drops. Nazaris et al. Described that there will be displacement of basilar membrane in the cross-section of the cochlea. It goes into the scala tympani in the apical part of the cochlear region. So the apical part control the low frequency of hearing. That's why patients with Meniere's get low frequency hearing loss. Another study by Honeybrook and Bird in 2016 has found out that the saccule, it contains otoconia. The otoconia can dislodge and cause blockage, and this develop into cochlear eye drops and endolymphatic sinus block. Another study by Shuknek and Gulia talk about rupture of resonance membrane. So as you can see here, endolymph is in the scala media. Endolymph, it contains a lot of potassium as compared to perilymph. So when there is eye drops, this will extend. The resonance membrane will extend and herniate to the scala vestibuli. Eventually, the restless membrane rupture. When the restless membrane rupture, the endolymph will mix with the perilymph. And this toxic level of potassium in the perilymph cause sudden change in the vestibular nerve firing. When this happens, this causes all the symptoms of Meniere's disease in the patient. After a few hours or days, this ruptured membrane will heal by itself, and the composition of the perilymph and endolymph will come back to normal. It restores its physiological state. Hence, the patient will have resolve in their symptoms. However, this can occur repetitively. That's why the patient can have recurrent problem in Meniere's disease, recurrent attack. Okay. So, what is the prevalence of this disease? It is quite common. The studies has described from 3.5 to 513 per 100,000 population. So the prevalence is variety. There's a variety of prevalence, but the biggest study done by Italy showed incidence of 8.2 per 100,000 population, and the prevalence is about 205 per 100,000. It is most prevalent between 40 and 60 years old. It peaks from 40s to 50s. And as the age of the patient increases, the prevalence increases as well. The ratio from man to male to female is 1:1. Some studies showed higher ratio in female, around 1.89 to 1. Okay. Bilateral Meniere's disease that occurs simultaneously is rare. However, there is always progression to bilateral disease in up to 25% of cases over time. Usually, the detrimental effect of hearing loss and balance function occur in the first decade after diagnosis. However, some patient has long-standing deficits in hearing and also balance, and this render Meniere's disease to be a chronic disease. So what's the natural cause of Meniere's disease? This is where we get confused, because one patient will talk about a certain cause of disease. Another patient comes with a different kind of cause of the disease. So typically, they present with unilateral ear symptoms, and this can last for decades. And attacks in the first decades is usually often and increasing in severity. Some studies have showed up to 6 to 11 attacks per year with periods of remission. And these periods of remission varies. Some patients have period of remissions for months, some others have period of remission for years. So in other patients, it is progressive with fluctuation that is unpredictable. So in the early stage of the disease, the frequency of acute vertigo attacks increase. After that, they have a remission. So this is confusing, right? So some patients come like this, some patients come like that. The vertigo can be stable in certain patients for a long time, but some other patients, they will present with another acute attack of vertigo after 20 years. This is the vertigo. In terms of the hearing, some patients can have worsened hearing, some patient has persistent hearing loss, and some patient has progression. So in a 20-year longitudinal study, showed 82% of patients with Meniere's disease will develop moderate to severe hearing loss. So this is debilitating, and some of them has bilateral problem. Because of all this uncertainty, a CPG was published last year to give us the best evidence-based management for patients with Meniere's disease. So I'm going to share with you this CPG today. They has come up with 16 key action statements for us to approach the management of Meniere's disease patient. So how do we do it? We do it step by step. And we hope that our patient can dance and twirl and turn like new kids on the block. I am so old school. Okay, the first statement is diagnosis of Meniere's disease, and this is a recommendation. When we say recommendation, there is evidence by systematic review, randomized control trial, and big studies with good number of patients or good number of samples. So they have suggested that clinicians should diagnose definite or probable Meniere's disease in patients who present with 2 or more episodes of vertigo lasting 20 minutes to 12 hours for definite Meniere's disease, or up to 24 hours for probable with fluctuating or non-fluctuating associated oral symptoms. So in the history taking, I know this is a repetition from yesterday, from many other lectures. We have to make sure that this patient is talking or is telling us the right history, that they are describing vertigo by this definition. So vertigo is defined as sensation of self-motion, rotary spinning, or movement of the environment when neither is occurring, or the sensation of distorted self-motion in rotation or spinning during an otherwise normal head movement. Yeah, and dizziness is defined as sensation of disturbed or impaired spatial orientation without a false or distorted sense of motion. For definite meanings, we have the patient should have vertigo instead of dizziness. Okay. However, we have to note that some elderly patients who has had Meniere's disease for a long time, they may not have vertigo anymore. And most of the time, they will come to complain about episodes of vestibular disturbance, imbalance, or vague dizziness. And in the history taking, we have to talk about, or we have to find out whether the patient has vestibular migraine or not. And I will talk further on this in the second statement. We have to take thorough otologic history. We have to know whether they had a prior ear surgery, whether they had infection of the ear, or prior hearing loss, and we have to ascertain whether it was sensory neural hearing loss or conductive. Medical and surgical history are important as well. Patient who has allergies, we have to find out this one because it has an effect to cause episodic attack of the vertigo in patient who has Meniere's disease. Neurologic history, if let's say patient has headaches or facial numbness, we have to rule out CPA tumors in this patient. Medications such as blood pressure, diuretics, and chronic vestibular suppressive medication is important for us to find out as well. Family history. Some subset of Meniere's disease are familiar. Hence, we have to ask whether there are any other family members who have similar symptoms, because these people can fall into the group of familial Meniere's disease. Social history, such as tobacco, caffeine, alcohol, all this can actually cause the vertigo attack in patient. Lastly, we have to find out how their disease or their symptoms affect them emotionally and psychologically, because we have to address those issues as well in the patient. Okay, I'm sure that we have gone through all of, or if not all, most of these differential diagnoses for patients. So you can refer to this again later to know what are the histories pertaining to each of the differential diagnoses to differentiate this from Meniere's disease. Then we should perform a thorough physical examination. If patient comes to us in remission, meaning they're not having any acute vertigo attack when they have Meniere's disease, the examination findings might be normal for everything. But this is how I usually perform vestibular assessment in my clinic. I will start with oculomotor. I cannot open. Now it's in. Oculomotor test. So this is fistula test. Oh, I cannot. Sorry about that. I will reshare my screen. So we will start with oculomotor test, fistula test, then skew test. Of course, there's no hard and fast rule about this. It's just how I do it. As you can see, I'm doing this in a child. This child doesn't have Meniere's disease, but I'm just showing that vestibular assessment can be done even in children. Okay. After that, whole Magee test or head impulse test. And then head shake test. So this is just a revision of what we have been learning since yesterday. You can find nystagmus there, which she doesn't have. Then eye movement. At the same time, I'll be looking for smooth pursuit, whether it's normal or not. This child has findings. Okay. can you see there's this conjugated eye movement in the child? Okay. Then I will do sakat. After sakat, I will do convergent test. See whether there's any abnormality there. It's not. And this diadochokinesia and pause pointing. Most of the time, after that, I will proceed with the OR suppression. This is normal in this child. Then I will ask them to do Romberg test and Gunn's positional test. Then we will look at their gait. For a child, she's very cautious. Usually child can jump around. This is her gait with her eyes closed. Again, very cautious. After assessing the gait, I will ask them to do Fukuda test. So from here, I will then perform supine roll test and Dix-Walpike test to rule out BPPV in a patient. As I said, in patients who are in remission in Meniere's disease, usually all these assessments are unremarkable. And the second statement is to assess for vestibular migraine in patients who we suspect to have Meniere's disease, and this is a recommendation. Why is this so? Because clinical features of Meniere's disease and vestibular migraine overlap, and the diseases can actually occur concurrently. VM patients are typically younger and more likely to be female, and this problem has been described by Prosper Meniere in 1861. He passed away in 1862. Prior to passing away, he wrote 6 journal articles in the Medical Journal of Paris describing all this problem. However, he hasn't been taken seriously until recently. Yeah. So for vestibular migraine, because we have had a lecture on this by Professor Dr. Raymond this morning, we can refer back to Barani Society diagnostic criteria, but this has to be ruled out in patient who has Meniere's disease. Okay. Pathophysiology of vestibular migraine is usually because of transient changes in chemical signaling or possibly cerebrovascular vasospasm. In patient who has acute attack, you can get nystagmus, which can be a central or peripheral feature. And if MRI is performed, you can see some changes in the cerebellar and deep white matter. You can see some lesion there. Okay. Statement. And this is strongly recommended in a patient who is going to be diagnosed with Meniere's disease. We have to perform hearing tests for them. And hearing test includes, so it differentiates probable from definite Meniere's disease. It has to include pure tone audiometry, tympanometry, acoustic reflex, and it also needs to include bone conduction threshold. And in the center that has this, we have to perform speech recognition or word recognition discrimination score. In Malaysia, not many centers do this. I know UKM has software for English, Bahasa Melayu, and Mandarin, and UIA has for English and Bahasa Melayu. Not many centers has this or does this. So in Malaysia, it's a bit restricted. Not even in my center, I don't have this one. If let's say you are in a center that doesn't have audiometric or audiologist, audiometric test or audiologist, we can at least perform tuning fork examination to know whether the patient has any asymmetrical hearing loss. And from tuning fork, we also can ascertain whether it's conductive or sensory neural in nature. By saying low to mid frequency hearing loss, we are actually referring to frequency less than 2000 Hertz. As you can see here, this is the cochlea unrolled. So when you unroll the cochlea, the scala media of the cochlea, at the base is where it mapped for higher frequency hearing, and at the apex, it mapped for the lower frequency hearing. So the scala media in the apex is wider and less stiff. So when endolymphatic hydrops happen, it is more stretched here in the apex of the scala media. That's why we get more effect in the low and mid-frequency hearing loss. Okay. The fourth one is utility of imaging, and this is an option. Most of the time when patient has asymmetrical hearing loss, when they come to see us, we perform MRI to know whether there is any lesion in the IAC or in the posterior fossa. And the reason why we want to perform this early is if, let's say, patient has any tumor like CPA, angle vestibular schwannoma, if we need to operate on them, it's better to operate while the lesion is smaller as compared to when it's bigger. However, we need to decide based on case-to-case basis in terms of whether to perform imaging or not. This is just to show an MRI showing endolymphatic hydrops in patient. As you can see, there's a bigger inner ear there. So if, let's say, we decide to perform an imaging for a patient, they have to know what are the risks, because usually we have to put gadolinium contrast to see all this. So we have to tell them about rare occurrence of anaphylaxis. There's a potential of developing nephrogenic systemic fibrosis in patient who has a pre-existing renal insufficiency. They can develop acute renal failure, and there's a risk of retention of the gadolinium in their body. So if any patient who would need a recurrent or surveillance MRI, for example, we have to consider all this and tell them. Yeah. Okay, so that's option for imaging. How about vestibular testing? Vestibular testing is not recommended. Why? Because it will increase or delay the time for treatment. 8 days costly, and not many places has vestibular testing. Even if those places has vestibular testing, the protocol and the setting is not similar from one to another. Okay. So results of vestibular testing and ecology often fluctuate in patient who has Meniere's disease. As you know, the natural cause is fluctuating, so the result is fluctuating as well. And the result, the degree, the result of the findings in the testing, they don't actually correlate with patient disability. Hence, this is not the best way of assessing the patient. So it is not recommended to do testing, vestibular testing in patient who we suspect to have Meniere's disease. Statement 6, patient education. Most of the time, we don't have much time to properly educate our patients. However, this is recommended to educate them on the natural history of the disease, measures to reduce their symptom or to control their symptom, and what are their treatment options based on the severity of the disease that they have. This is to ensure that you have their compliance when you are treating them with medication or with therapy, so that they really follow and understand the natural cause of the disease. If, let's say, we don't have enough time to educate our patients, since we are seeing them on multiple appointments, we can reinforce on the education from one appointment to another. Okay. Statement 7 is about symptomatic management when they come to us with acute vertigo. So we should offer limited course of vestibular suppressants to reduce the severity of the vertigo. Okay, this is recommendation. So how does vestibular suppressants help patient? It appears to act by suppressing central vestibular neural activity at the level of the brainstem, concomitantly reduce vertigo and also nausea. So 3 groups of medication that we use, which are first generation antihistamine, benzodiazepines, and anticholinergic. The chronic use is not advisable, not desirable, because it will reduce the central compensation, and this can lead to perpetuation of chronic imbalance. So it has been found that among the 3, no medication is superior to the other, and it only should be used for several days. By several days, they didn't specify how many days, but for me, I only use for 3 days most of the time, and patient will get better. So these are, one second, my face is, can't go any smaller. Okay, so the first generation antihistamine, you can use anything that is available at your center. These are the common ones being described in the literature. So first generation antihistamine crosses the blood-brain barrier and binds to several neurotransmitters, including these 2. They suppress vertigo and nausea likely with equal efficacy, so any one of these can be used. benzodiazepine. These 3 types can be used. And as a centrally acting anticholinergic medication can also be used. But this one, you have to be very selective in giving to patient because of the side effect profile and potential toxicity if it's being used for a longer period of time. Okay. Statement 8 is about symptom reduction and prevention, and this is all about education of the patient to change their dietary and lifestyle. And this is in the purpose of reducing the symptoms and also attack. So one of the things that can be done is, these are the things, the list of things. It has been shown that high salt diet cause acute vertigo in patients with Meniere's disease. And there's a limitation of salt intake every day. The ideal number is 1,500 milligram per day, but they shouldn't be consuming more than 2,300 milligram per day. So if patient asks me, how do I go about this, doctor? So if they eat out a lot, they can check the level of sodium from nutritional fact online or from the packaging of their food, their processed food or things like that. I always advise that they should cook themselves and they can measure how much salt they put in their cooking. Caffeine, alcohol, and nicotine has been shown to cause vertigo attack in Meniere's disease as well. Hence, they have to reduce the amount of caffeine, alcohol, and nicotine that they take. So easiest way is to tell them to eat well-balanced meal throughout the day, hydrate themselves, and make sure they avoid high sugar beverages. Another thing that has been associated with Meniere's disease is allergy. Hence, if patient has any type of allergy, we have to help them and treat those allergies as well so that they don't trigger another acute episode. The other things that they have to do is managing their stress. They have to get plenty of exercises. They have to get enough sleep with good sleep hygiene. Joining a support group has been shown to be beneficial for patient. Writing a journal, sometimes they can write a diary on when their attack happened, and then they can just look back on the patterns of triggers that can cause their attack, and then from there we can work out what they should be avoiding or what they should do better in terms of managing their symptoms. Things like breathing exercises helps as well. Acupuncture has been shown in certain research to help patients with Meniere's disease symptom. However, the study design is not well done, hence they cannot make a recommendation on acupuncture. And some patient with Meniere's disease has been shown to have sleep apnea. Hence, if our patient complain of any suggestive symptom of sleep apnea, they have to be properly assessed for this. Statement 9 is about oral pharmacotherapy for maintenance of symptom. And this is talking about giving diuretics and beta-histine for patient to maintain them to be asymptomatic. And this is actually an option. Okay. Diuretics are believed to alter the electrolyte balance in endolymph, subsequently reduce the endolymphatic hydrops. Systematic review has been done. And some did report improvement in patients' vertigo with the use of this kind of medication. There are many types, hence we have to select what kind of diuretics which is suitable for each patient. So thiazides are contraindicated in patients with gout, and potassium-sparing diuretics are contraindicated in patients with acute or severe renal failure. Hence, we have to properly choose this. And then there's, of course, some surveillance that we need to do for the patient, monitor their electrolyte and blood pressure. So the studies that has described the use of diuretics, duration of use varies from 10 days to 24 years. Hence, of course, if we want to use this medication for patient, we have to properly monitor and assess which one is suitable for which patient. Okay. About beta-histine. Beta-histine is a histamine analog that strongly antagonizes histamine H3 receptor and a weak agonist of H1 receptor. A Cochrane systematic review in 2016 has been done, and it shows beta-histine is better than placebo in controlling vertigo. So patient has report Patient reported 56% reduction in their vertigo after they took beta-histine. There's another trial called BMAT trial that give 3 interventions. One is placebo, another one is low dose beta-histine, and another one is the high dose beta-histine. And patient were followed up for 9 months. They were given the medication for 9 months. So after 9 months, all 3 groups has claimed that they have reduced symptom. So we can't really say that beta-histine, either low dose or high dose, is better than placebo in this sense. But since it gives a reduction in the acute vertigo attack, so we would say that beta-histine is beneficial. However, this is only an option, and again, we have to see a patient's response in terms of their symptoms. So it's patient-to-patient basis. A long-term use, the longest study is 9 months use of beta-histine. Okay, most of the time it's well tolerated. There's only rare medical side effects such as headache, balance disorder, or upper GI problem. However, we have to be very careful in using beta-histine in patient who has asthma or peptic ulcer disease, and it should be avoided in patient who has pheochromocytoma. Okay. Statement 10. I am honestly not familiar with positive pressure therapy, giving pressure via the ear canal to the middle ear, but it shouldn't be done. If you used to do this, you should stop doing it because there's a recommendation against using positive pressure therapy for patient who has Meniere's disease. Okay. 11. Intratympanic steroid therapy, we should offer it to patient who has active disease that is not responsive to medical therapy. And this is also an option. So we have to see it case-to-case basis. Most of the time, this is how any intratympanic injection is being given. We put local anesthesia into the ear canal and let the patient wait for maybe around half an hour. After that, the injection is done via the tympanic membrane. So what's the benefit of intratympanic steroid therapy? It's improved vertigo control. There is no risk of hearing loss because it's not an ablative therapy. There's less risk of intratympanic steroid therapy as compared to oral steroid. It improves quality of life in the patient, and there's no loss of vestibular function. The mechanism of action of steroid in reducing vertigo is by stabilizing the vascular endothelium and improves cochlear blood flow through anti-inflammatory effects, as well as it affects the cochlear ion and fluid hemostasis. So there's a variable result in studies to show what is the effect of steroid to vertigo control, tinnitus, and oral fullness, and reduced hearing. In general, it's well tolerated, very low level of complication. Most commonly is post-procedure otitis media, which is around 7%, or persistent tympanic perforation, up to 38%. So most of the time, the medication that I'll use are methylprednisolone and dexamethasone. So the way they act in the inner ear is slightly different. Methylprednisolone penetrates through the round window and achieve higher concentration in the endolymph. It's faster than the dexamethasone. However, dexamethasone is more rapidly absorbed into the stria of the inner ear and the surrounding tissues. So that's how they work. Definitely, if patient has usable hearing and intractable vertigo, you can offer this for the patient. Usable hearing, I will show you in the next slide. This is the recommended dosage for both dexamethasone and methylprednisolone. So we can inject from 0.8 to 0.8 ml, 0.4 to 0.8 ml into the middle ear space from once only. So you can try it once, or up to 3 to 4 sessions in every 3 to 7 days duration, depending on clinical response of the patient. So if the patient gets better, probably once is enough. Yeah. Okay. The next one is we should offer intratympanic gentamicin therapy if a patient has active Meniere's disease that is not responsive to non-ablative therapy, which means medication or also intratympanic steroid, and the patient has no usable hearing. So the easiest way of giving is like this. Just inject straight into the middle ear via tympanic membrane. there are other methods that will be discussed later. So what's the benefit? It improves vertigo control, improve quality of life, patient return faster to work, and it avoids general anesthetic because this is an office procedure. It's not an operation, but there is a risk of hearing loss, which is not as severe as surgical labyrinthectomy. It improves safety in patient because there will be less risk of fall and because patient is better. Okay, so gentamicin is an aminoglycoside antibiotics, causes toxicity in the inner ear. It attacks the hair cells in the vestibule and also in the cochlea. While it is most both cochleotoxic and vestibulotoxic, gentamicin works better, or it can chemically ablate the vestibular system better as compared to the cochlea. Okay, so it has been shown that it decreases vertigo symptoms in Meniere's disease patient, and it is definitely less invasive than surgical ablation. By surgical ablation means it's an operation. Okay, so methods besides just injecting straight away through the middle ear using a needle, we can insert a ventilation tube, grommet, with or without catheter. We can insert a catheter, microcatheter into the middle ear as well for the injection. So systematic review showed that it reduced vertigo in patient. Some patient has no symptom up to 1 year of treatment. Okay. It is well tolerated. It improves vertigo, and there is low incidence of severe hearing loss. So hearing loss can happen, but most of the time is not severe hearing loss. We have to be cautious in patient who has bilateral Meniere disease. Because if this happens, then the patient will have no vestibular function, and hence they can have reduced hearing and also no vestibular functions. They will be chronically dizzy and having imbalance. We always have to make sure that we assess the vestibular status and also the hearing status of the other ear, because some patients can develop bilateral Meniere's disease. Hence, we have to weigh between the cost and benefit of whether the patient will benefit from this or whether the patient has higher risk of developing bilateral disease before we suggest for intratympanic gentamicin injection. Regarding the dosage, the literature has support dosing on a weekly or as needed basis, because if we give high dose or infusion therapy, the patient has higher risk of developing hearing loss. Okay, so some patients are investigated using vestibular assessment after the injection. VAM has been shown to be more reliable predictor of vertigo control as compared to caloric testing. So after the injection, we can do VAM to know whether the patient has a good response or not. After injection, if we do the assessment, patient can have positive head thrust, and definitely prior to the treatment and after the treatment, hearing test with word recognition score should be performed to assess for hearing loss in the patient. So the education prior to giving IT gentamicin injection is to tell the patient about persistent tympanic membrane perforation that can happen, hearing loss which can happen. There is need for multiple injection. If let's say the response is not, the initial response is not good, then probably we have to do multiple injection. And the possibility of lack of central vestibular compensation after this chemical ablation, and possibility of a surgical labyrinthectomy if let's say they don't respond to this fully. And in patient, they have a risk of developing bilateral Meniere's disease, maybe as high as 50% in certain studies. So we have to caution them that maybe now they don't have bilateral Meniere's disease and you give that treatment. If later they have the bilateral Meniere's disease, then they will have chronic imbalance as well. Another thing that we have to counsel the patient about is a possibility of vestibular rehabilitation therapy if let's say they cannot achieve central compensation fully after the treatment. Next one is surgical ablation therapy, which is a recommendation. So clinicians may offer or refer to another doctor who can perform labyrinthectomy in a patient with active Meniere's disease who is not responding to the other therapy and have non-usable hearing. So this is in a patient who don't have usable hearing anymore. Okay, definitely it's definite vertigo control because we wipe out the labyrinth, and it stops. We can stop the other types of treatment which can also give side effects to patient once this is done. And it is also a treatment for drop attack. In the severe end stage Meniere's disease, patient can present with drop attack or two-marking attack where they just drop without losing their consciousness. So if let's say patient has a drop attack already, labyrinthectomy is one of the treatment. And to whom do we offer this? We offer them to the small subsets of patients with persistent symptomatic unilateral Meniere's disease, which is intractable, not responding to conservative treatments, and they don't have usable hearing. So non-usable hearing is category D, when the word recognition is less than 50%. So this is the subset of patient that we offer this treatment. Okay. Possible is to completely remove abnormal sensory neuroepithelium in the semicircular canals and otolith organ in the ear, because these are the reason why patient has a vertigo. The success rate to relieve the vertigo is estimated to be more than 95%. And the vertigo control is defined as no episodes of vertigo within 6 months period. So in 6 months, no vertigo, which they can get after 18 to 25 months following their intervention. So major comorbidities that can happen with labyrinthectomy is complete vestibular and hearing loss. And when this happens, they will start to have worsening tinnitus in the affected ear, and they can have prolonged postural instability if, let's say, central compensation did not take place properly. And we have to caution them that central compensation may take weeks to months to even a year. And some might not recover fully, and they experience persistent imbalance. Of course, prior to this operation, we have to do evaluation of their audiovestibular function, their hearing test as well. And nowadays, we can also discuss with them about hearing restoration together with the labyrinthectomy, or maybe after via cochlear implantation. As we know, as we wipe up the whole of inner ear, they will have no more hearing, hence cochlear implantation is a choice for them. This is a transmystoid view of left lateral labyrinth. These are the semicircular canals, and this is the CP angle. You can see the cerebellum and CP angle with all the nerves and vessels. Other surgeries that we can offer to patient are vestibular nerve section. This one should be offered. Vestibular nerve section means we divide between the cochlea and vestibular part of the vestibular cochlear nerve, and we cut the vestibular nerve. So this is offered only in select cases of active vertigo unresponsive to all therapies, but they have usable hearing. And there's no evidence of contralateral disease, and patients' expectations should be ascertained prior to the operation, because a lot of things can go wrong, and they can still have risk of hearing loss. This also can be offered to treat two-marking attack. Endolymphatic sac surgery has been described in the literature for many times. There are multiple types, but there's no recommendation to offer patient this one because it hasn't been shown to be beneficial. There was one study with intervention of sac surgery versus only mastoidectomy, and both group of patients has showed tremendous improvement in their vertigo, up to 70%, even though they only had mastoidectomy. Hence, that's why the endolymphatic sac surgery is not recommended yet to be beneficial for patients who has Meniere's disease. Okay, the next two statements, which is 14A and 14B, is on vestibular therapy. And vestibular therapy should be given to patient who has chronic imbalance, meaning it can either be interictal instability following ablative therapy after gentamicin or after labyrinthectomy. So patient has imbalance, so we have to start them on vestibular therapy, or if patient have chronic imbalance from the disease itself. Hence, we have to offer vestibular therapy for patient. So this afternoon, we're going to have many talks on vestibular therapy. So I will not talk further on what kind of therapy and things like that. The second assessment, the second statement on therapy is we shouldn't offer vestibular therapy in patient who is acutely having an attack. So it is not safe because they're having a severe vertigo, so they can have fall. So when they come to us in acute attack of vertigo, we shouldn't be giving them rehabilitation therapy at that point in time. Okay. The next statement is on counseling for amplification and hearing assistive technology. As we know, Meniere's disease come with reduced hearing as well. So it's a bit tricky. However, we need to recommend amplification or rehabilitation of hearing for patients with Meniere's disease. So initially, when patient has mild sensorineural hearing loss, it is a bit tricky to fit them with hearing aid because the level of hearing will fluctuate. Hence, if let's say they have a prolonged over amplification of the ear, then they can proceed with noise. They will proceed with noise-induced hearing loss. So it's tricky to fit hearing aid in those kind of patients. Later in the clinical course of Meniere's disease, they will have reduced hearing together with poor speech discrimination. At this point in time, the dynamic range of the hearing level would be very narrow, and sometimes they find it difficult to use hearing aid. Yeah, when this has happened, when the dynamic range is too narrow, cross hearing aid can be used for the patient. However, if the patient has severe to profound hearing loss on one ear, but a normal hearing on the other ear, using cross is a bit frustrating for them. So in this kind of case, we can offer BAHA, bone-anchored hearing aid for this patient. And if patient has profound hearing loss, cochlear implants is another choice that we can offer the patient. Last kali. The last statement is talking about documentation. So each time we see the patient, it is important for us to document either resolution, improvement, and the course of the disease, because from there we can see whether we need to offer a new kind of treatment, whether they are responding to the current treatment that we have given them. So documentation, of course, is always important in medical field. So this is not something new. Yeah, this is the algorithm that can be used in managing patient with Meniere's disease. This CPG is available online. Of course, you can download it and read up on all the steps and the studies that they include in the CPG to come up with this 16 action statement. Thank you very much for listening. You can reach me at this email. Thank you.